Atamari everybody, my name is Leanne Takaru and I am part of the Māori Rōpū of the Health Quality Safety Commission, and it's fantastic to see so many people here today. I will leave the official welcome to the boss, to Janice, but it is exciting, and I know that we will have an exciting day because Chris and Linda, who lead the consumer engagement team, have organised today, and they personify innovation. Fantastic people who I know will ask for us to be more responsive in this space throughout the day. So I'm sure that it'll be a dynamic day for us all. And of course it is an area that we do need to be more responsive to. Last year I heard Sir Muir Gray say we've been through a bunch of different eras in terms of healthcare delivery across the world, and we're looking now to make sure this is the era of individualised healthcare. And I was thinking when he said that of some big extrapolation to some scientific realm, perhaps pharmacogenomics, and he looked at me and he said, no, simply that engagement with the people in front of you. You know, I don't think we do so well across the sector in terms of healthcare professionals collaborating optimally, but certainly often forget the person who is the expert of their own health, and we need to make sure they're included in that space as well. So without further ado, I will hand you over to the CEO of the Health Quality Safety Commission, Dr Janice Wilson. But I would like to say that I know Chris and Linda are wonderful people who are innovative in this space, but it is all premised on the leadership of Janice. And I have been so lucky to have come to know Janice at a professional level over the last 3 years. And in my experience, it's quite rare to have a big picture thinker person alongside the machinations of that micro level, and she is a remarkable woman who knows about collaboration, communication optimally. So Dr Janice Wilson.
Tēnā koutou, tēnā koutou, tēnā koutou katoa. And greetings to you all, and many thanks, Leanne, for that welcome. I think that if I'd known what you were going to say, I wouldn't have asked you. I thought that before I start, it's really, I would like to say it's really great to see such a great number of you here, and a wide, varied number. And I can see people that I recognise from all walks of life in the health sector. So I thought it would be useful to kind of know how many of you are actually consumers and come with that particular hat on today. I suppose you could put two hands up, couldn't you? And the rest of you are providers? No, not all of you. Family members? Some of you family members? Yeah. All right. Anyone that I haven't included that's got a different hat? Bureaucrats. Oh. Bureaucrats. Oh yeah. Oh, there are those of us. Yeah, bureaucrats. Okay. Well. Welcome to you all. I think this is going to be a very exciting day. It's the very first symposium, I guess, that we're running that's focused on our Partners in Care program. It's called a show and tell, and I know that there'll be a lot of that and a lot of discussion, a lot of sharing, which is what happens in true partnerships, a lot of sharing. So looking forward to all of that today. As we start, I thought it would be useful just to talk to you a little bit about the Commission. Some of you mightn't know too much about us. We're about 3.5 years old and formally established under the New Zealand Public Health and Disability Act. We're a Crown agency under the Crown Entities Act. We've got a board of now 8 members. We've just had a revitalisation of our board. I guess we've had some new members appointed. And every organisation, of course, has a parent body and a grandparent body. There's always a history, and when we started we took on the mantle and also many of the programs of the former Quality Improvement Committee, which was a different beast. So we have a historical past, but we've actually taken that history into the present and into the future and trying to look differently about quality improvement and patient safety, and particularly about consumer participation and engagement in services. So our role is to lead and coordinate work across the whole health and disability sector for the purposes of monitoring and improving the quality and safety of health and disability services, and helping providers across the sector to improve the quality and safety of the services. So we like to think about our work in three different ways. We like to think about us shining the light on particular issues that we might want to tell the public about, tell government about, tell you all about, but to kind of report in a sensible and intelligent way. But at the same time, our work is about lending a hand to people through our expert advice, through guidance, through tools, and through a focus on quality improvement programs and helping people focus on what they do every day with that kind of lens. And I often say I want people to wake up excited every morning about how they're going to think about improving their work and the quality that they do, and how they're going to focus on patients and families. And thirdly, I've already said this, that we want to bring an analysis and an intelligence to our thinking and our work, and to be an advocate for change. So the way we work is really by facilitation and support. We don't have any legal powers. We can't make people do things. We've got no big stick that we can wave. So we have to form really good relationships with people and facilitate and convince people and persuade. So it's about working, and this is, I guess, where the word partnership comes in, working in partnership with others. And we do draw on other people's experiences right across New Zealand, because we're not don't have all the bright ideas ourselves. The bright ideas are all with you, and also people overseas, of course, also are doing some great things, and we draw on that as well. And you'll all know, I hope you do know, that we base our work on what's become colloquially known as the New Zealand Triple Aim. Now, the Triple Aim was a concept that was formed by the Institute of Health Improvement in Boston, but we've taken it to have a more New Zealand flavour, in particular talking about the best value of the public dollar spent. So we don't talk about reducing costs, we talk about spending money in the best possible way, with still the focus on the individual, on the patient experience or the person's experience, and also on the population, looking at improving health and equity. Now, for a long time I've always thought about quality as also having a triangle. Even some of you will know that I worked in mental health for a long time, and I used to talk about this to mental health audiences, and the triangle being leadership from clinicians, but that's also from around capability. So it's about building capability at all levels and understanding quality, with leadership being core. Secondly, about the participation and engagement of consumers or patients and their families, very key, underpinned by information, good information, and understanding that information. So these are the kind of three elements, if you like, that I think about quality and quality improvement. So our focus has been on these three key areas. We call them our kind of strategic focus areas. That's building capability in clinical leadership, looking at analysis, evaluation, information, and thirdly, but very importantly, consumer and family engagement. And because we're a small organisation and we had to focus and do some things, it's always good to demonstrate some of these strategic things through something practical that people can understand. We have focused on 4 patient safety areas of reducing harm from falls, which is predominantly around inpatient falls, but also falls in the community and in aged residential care. Healthcare associated infections, so those are those infections that people pick up when they're engaged in the health service, mostly in hospital. Medication safety, all of us take medication, even if it's self-prescribed. It's kind of a bit ubiquitous medication, but medication safety is incredibly important. And what Leanne didn't say when she was up here is it's one of her areas of expertise. And harm from surgery, so adverse events that happen from surgery. So those are the 4 kind of key areas that we have to date been focusing on. But watch the space, because we're starting to move more, I think, into engaging with primary care and other community services, and we're kind of on a roll to looking at how we extend some of our focus as we go forward. I've said that we don't have any powers, so we don't do complaints. That's the Health and Disability Commissioner's jurisdiction. We can't enforce anything. We don't do quality assurance, we don't do certification or accreditation or credentialing or registration, any of those kind of assurance activities. And you'll be relieved to know we don't fund services. Kind of frees us up to be a bit independent, I guess, and to say some things. So I was thinking about what I could... That's just a kind of summary of, a quick summary of who we are in case you haven't read much about us or been onto the website. I was thinking about what I could say to set the scene for today, which is really about partners in care. So I thought that very simply I would just do an acrostic on the word partnership. So here it is. I find this funny type, as you do when you're on the computer. So I hope you can read it. So, what is a partnership? And I guess, a partnership is simply when 2 or more people join together for any specific purpose, and you kind of call that a partnership, which has a true spirit, where there's the true spirit of partnerships, where there's a contribution between those 2 or 3 people, and they work together towards a common goal. So I suppose that's a very simple definition of a partnership. And there are all kinds of partnerships, as you know. In life, there's the one that you have if you live with someone or marry someone or commit to a personal partnership. There's legal partnerships. There are corporate partnerships. There are partnerships between government parties in our government. That's a funny kind of a partnership, I guess. However, the first word, the first letter, as I said, they all have a common purpose, which is an agreed or shared goal. So I suppose within the health and disability context, that's about really finding out what the problem is, what the cause or what are the issues that one person might bring into the partnership, what are the contributing factors, what can be done. Is there a cure, is there not, how can it be managed, how can it be reduced? So the purpose of the partnership in health is really around the individual or the family's issues that they bring to the table. And then the provider, part of that is contributing to what their knowledge and skill is to analysing it and offering solutions, the purpose. But a partnership only works if there's really good acknowledgement of each other's perspectives and points of view, and understanding, the authority that parties bring to the table in the partnership and to the issues and to the discussion. So if a partnership's to be authentic, because we want partnerships to be authentic, then it's about partners being themselves, being yourself, being honest, saying what you think and what you really believe. So acknowledge, thinking about authority and being authentic. Respect, pretty fundamental in a partnership. Being respectful to each other in terms of all interactions, respecting each other's point of view, respecting each other's humanity, and respecting cultural differences or other differences, and showing that respect. So that's also about respect for the rights of individuals, which is also about patients' rights under the Health and Disability Act, But importantly, I think respecting vulnerabilities, because as we'll see later on, this is not entirely an equal partnership. And I was kind of reminded about this. We've got a pilot now on our board as a board member. His name is Bob Henderson. He's the chief training pilot for 737s. And he was talking about the issues of vulnerabilities in health, and I said, oh, you know, when you fly a plane, you know, you're pretty kind of trusting, and you do feel quite vulnerable because you place all your trust in the pilot. And he said, oh, but he says that's not nearly as bad as placing all of your trust in a surgeon. And how vulnerable you are when you're actually unconscious and anaesthetised, and that's true. So it's about respecting vulnerabilities. So T, taking time to listen. It's about communication really, but listening is probably the most fundamental and important part of communication, as well as talking and talking together, and sort of the foundation of building trust, you know, taking time to listen, talking together, building trust. And good communication, as I said, is key because you have to understand each other and each other's way of thinking about the world and understanding the world and where each person comes from. So good communication builds trust. And of course, good communication is about understanding each other's needs. So finding out about those needs is key. Not just the needs of the consumer and the family, but you know, the provider probably has some needs as well. What do they need to do in order to be able to help and deploy their knowledge and skill in the best possible way? And that's pretty crucial. So I think there is an onus on consumers and families to understand that perspective too. So needs. And then finding out about each other's expertise. Everyone brings their own expertise and experience to the table, and that's central to any effective partnership. Every one of us has got expertise and experience, and we bring that into a relationship with a provider. We have knowledge and skills, may not be the same, but it's important that is acknowledged. From both sides. So that's also about getting to know each other and building the trust that needs to happen. So another R, responsibilities. So each person has responsibilities. Responsibilities, I suppose, to understand vulnerability, responsibilities to listen and to communicate, responsibilities to engage together on this journey of healthcare. So the responsibilities, of course, are different from each side, from the provider side and the consumer side. Creating a safe environment for discussion is very important. Having safety. It's not just about safety, you know, to disagree or and to look at how you can compromise and build good collaboration. And although you might say it's not often that one compromises when you're in an individual provider-consumer relationship, there's often quite a lot of compromise that goes on in co-design, when people are involved in co-design of services or at a governance level are participating or involved in other ways of planning or evaluating services. So there needs to be safety for disagreement and compromise in that collaborative environment. But environments also need to be safe. Of course, that's kind of our core business, looking at how to avoid harm, to create environments that are safe to speak up, as well as avoiding harm, to admit mistakes, safe to admit mistakes and to admit error, environments that are supportive for providers as well as for consumers. And this also includes cultural safety. So a partnership needs to be a safe place. And harness, H for harness. Successful partnerships harness each other's strengths. So they work from a kind of strengths base. They bring resources, each brings resources to the table. And it's about building forward on those strengths and working together to the common purpose that we've talked about. Information, one of my favourite topics, information. So you can't really have a partnership without good information. It's kind of fundamental to understanding what's going on. It's the basis, of course, of health literacy. It's a basis of being able to build the relationship and the partnership that's required. And it needs to be kind of really clear and understandable, and good, understandable information empowers everyone. It empowers us all. So it's about how that information is presented, and it can be done in creative and innovative ways. And we're going to, I think, look at how we look at innovation in the way to present information. And lastly, another P, and I thought I'd leave this to last, P for power. Because, of course, the kind of partnership that happens in health is not really an equal partnership, and that does have to be kind of acknowledged, I think. There is a vulnerability, there is a handover of power, often from one partner to another. There's an inability to access the same kind of information or even understand the issues in the same kind of way. And everyone at the table needs to be really mindful of this and really understand this. Of course, we have other relationships in life where we have unequal powers. I think every time I take my car to the mechanic, I don't really think that I'm in the same position of power that he's in. But, that's different. It doesn't really affect me as much personally. So there has to be a greater effort to work on this and to acknowledge this issue. And really this is at the heart, of course, of building trust within the health sector and partnerships in the health sector and partners in care. So that's my acrostic on partnership. And that's what we're going to be hearing today and talking about. And I'm really looking forward to it. So tēnā koutou, ka koe.